Thank you for having me here to talk to you about active surveillance, follow-up protocols, and risk stratification. So, what I want to talk to you about is the need for local active surveillance protocols, and how to take on improving your own hospital's active surveillance, prostate cancer's UK's role in my development of my protocol, um, and how to get your active surveillance protocols up and running, how to develop them, and how to implement them in your institution. And I'm going to do that by telling you how I've done it in mine, and then also some further refinements that are planned for active surveillance here in my local hospital in Bath. So active surveillance in Bath. For context, I'm a relatively new consultant. I've been in post as a consultant in Bath for just 2 years in October. And before that, I was a registrar in Bath. And I noticed as my time as a registrar and in my early stage of being a consultant that active surveillance for prostate cancer was a bit like this squiggly line of chaos that you see on the side of your screen. And I wanted to try and smooth that out and make it a much more uniform process. I also noticed that some of our nursing staff who were trying to predominantly run the active surveillance clinics were a bit like a headless chicken, because every different clinician undertook different practice for their active surveillance. It was all a bit chaos theory, and this led to insecurities in the nursing staff running the program. And it also led to insecurities in the patients, as the nurses weren't able to tell them what PSA intervals they would be having, when they would be having a repeat MRI or indeed another biopsy. It was very clinician dependent. Now, the success of active surveillance really requires patients to be confident that they are undertaking a sensible monitoring strategy and that they will be correctly transitioned to more radical treatment if it's required. There have been a number of studies looking at reducing anxiety in active surveillance and identifying time points within active surveillance that men find stressful. In the studies, it's been found that men undergoing active surveillance have a moderate risk of cancer-specific anxiety, but that significantly decreases over time. The greatest disease impact on the men's well-being was at the time of diagnosis, and the studies show that they have subsequent cyclical anxiety and fear around their disease monitoring appointments. They're all worried about progression quite naturally at that point. Donaci's performed a scoping review looking at interventions that can be used in active surveillance to help deal with the anxiety. And they categorized those into some major themes, some of which I'll touch on a bit as we go through. Information and education being key, coping and psychological support, and lifestyle. The psychological support for men undergoing active surveillance should include the involvement of their family members or friends, close friends, during their decision-making process for active surveillance. It's also clear from the studies that they should have access to tailored information about prostate cancer treatments, all of the treatments involved in the pathway, and the risks and benefits of each. And they should be made aware upfront of trust surveillance protocols and given information on lifestyle adjustments. There's a recognized need for healthcare providers to actively promote physical activity and nutritional improvements. And these physical activity programs instituted in men in active surveillance may be what increases their longevity and their overall survival. And there's evidence to show that men with prostate cancer can live longer than the standard natural population, possibly because of the impact that a regular interactions with clinicians, helping them with their cardiovascular disease status, their nutrition, exercise, health, and lifestyle can have on their overall well-being. But I digress ever so slightly. But I think you can see from this that it is important for active surveillance confidence that men know what they're doing, which in the previous chaos theory we had was going to be very unachievable. So with the help of PC UK, as I became a prostate cancer UK clinical champion about 18 months ago, and at that time I was starting my career, and I looked to develop a program and a project to do alongside the Clinical Champions program. And my active surveillance protocol just seemed to be the area to work on. The Clinical Champions program looks at supporting change leaders to develop their skills and to know how to embed change into their departments, hospital, and wider healthcare networks. It really gave me the springboard to push forward the project of improving active surveillance. I developed a lot of networks that allowed me to ask others how surveillance protocols were working in their departments, and helped me really learn how to go about making a change that was sustainable in my department. And that's sort of how I came to developing my program. Now, I wanted to talk to you about guideline protocol development. That's the whole reason for my talk. I'm, however, not NICE, the National Institute of Clinical Excellence, who develop guidelines for us all of the time. My knowledge of how to come about and make a protocol is part learned, part taught through PC UK's programs, part just developed over time with the audits, research and things that I've done. But when I was thinking about this talk, I wanted to look about how people really go about developing guidelines. As you can see, it can take up to 2 years to get a NICE guideline. But I wanted to show you this flow diagram from NICE because I thought this is far more evidence-based about how to develop a guideline than anything I could ever tell you or give you. It turns out I did follow very similar patterns as NICE. It didn't take me 2 years, but it has taken the best part of 12 to 15 months to get my protocol to where I wanted it to be and up and running as it is now. The first thing to do is to identify your need, and that's topic referral. I identified our need for active surveillance, and then I went into scoping mode to look what's out there already. Do I need to reinvent the wheel? Is there already something that could fit within my hospital? And the same for your hospitals. Is there already a protocol that would fit? It may not necessarily be mine. There are other departments out there doing things differently. But is there something that you could adapt for your own needs? Development phase. That's taking what you've learned, what you've scoped out, and can you construct a program that will fit with your institution's needs? Everyone has different access to radiology, different access to clinic rooms for nurses. There's things about every department that will be different. And in your sort of development phases, that's where you work on what will work for you. The consultation phase, this is the discussion with all of the stakeholders. You want to make sure that you're obtaining buy-in for your protocol and your program. Trial it, validate it in your setting. Validation might be doing a few men and ensuring that everyone's happy with your protocol, making sure that radiology don't think it's increasing scan numbers, etc. And measuring your impact, either quantitatively or qualitatively. And then the publication is what it says on the tin. Tell everyone what you've done. So as I said, I realized as I looked at this that perhaps I did a similar thing. So my scoping and evidence review, I looked what was out there. I read lots of articles on surveillance, on patient anxiety on active surveillance, and any other evidence regarding active surveillance I could get my hands on. I talked to my nursing colleagues. I wanted to find out how how it felt to me that they were not feeling confident running active surveillance clinics because of the chaos theory, but I needed to get palpable evidence on that. So I did some sort of semi-structured interviews with them to find out how they felt about it. And they all wanted greater clarity and uniformity across the doctors managing active surveillance. I also spoke to some men on active surveillance to see how they felt about active surveillance here. They were all very complimentary, in fact, and I think the patients had less appreciation of the slight variations in practice than I felt they did, which was good. But following on from my evidence and scoping, I then set out to work out who qualified for active surveillance at my institution. I also wanted to think about the frequency and timing of interventions to optimize care, but minimize those anxiety-provoking events. I decided that I would stratify our active surveillance into two pathways, a lower risk active surveillance pathway and a slightly higher risk active surveillance pathway. The nomenclature of our pathways is still slightly up for debate, as we didn't want men to be being concerned about being on a higher risk pathway. So we may change the nomenclature to low risk active surveillance and standard active surveillance. As we've been trialing and moving things forward, it's been felt that that would be a better terminology. So once I looked to stratify, I then sat down to, with all my evidence, develop the protocol into these two streams. There's no absolute guidance about the timings of repeat MRIs or confirmatory biopsies in active surveillance. There's no hard and fast musts. The only guidance is from NICE that Cambridge prognostic groups need to be referenced. I also wanted to set about developing a patient education plan so that men on active surveillance know when their anxiety-provoking events are going to be, when they'll have their PSAs, when they'll have repeat MRIs, where to call for help. And we are in the throes of developing an active surveillance treatment pathway that will be filled out at the beginning of active surveillance and given to men so that they have a treatment summary of what to expect. There's also been work surrounding educating my nursing colleagues and my fellow clinicians in how to implement active surveillance in our trust. Alongside developing the protocol, an important part of the work was to identify the key stakeholders and engage them. If you've done anything about stakeholder engagement, you might recognize the power interest matrix, and it's looking at the different stakeholders who may be very interested but not have a lot of power in your study, or versus those that have a lot of power but very little interest, and how do you relate to all of those people to keep them on board. It was important to identify people like the GPs, who I'm changing the way that we've been doing active surveillance here in Bath for decades, and at a 5-year point I'm hoping that they will take over annual PSA surveillance, and it's been important to be in discussions with them to make sure that they are happy with that. As I've mentioned, radiology are also a key stakeholder alongside the consultant nurses, specialists, pathology, and our GP colleagues. So the RUH active surveillance protocol, I won't read everything out to you because I don't wish to insult you, and I know that you can all read. But as per the NICE guidelines for active surveillance protocols, it is referencing our Cambridge prognostic groups. Essentially, in our inclusion, we're looking for men who have low to intermediate risk prostate cancer, who are fit enough to go on for radical treatment. Now, that's a key thing. Men must be fit enough to go on for radical treatment. If they are not fit enough for radical treatment, that's not necessarily just through age, that could be through comorbidities, then active surveillance shouldn't be for them, and they should be counselled towards watchful waiting instead. But men that are suitable for active surveillance fall into those Cambridge prognostic groups 1 and 2, and rarely CPG3 in well-informed men who can be safely monitored with PSA, MRI, and as required biopsies. Our exclusion criteria are men who are not fit for radical treatment, those with higher Cambridge prognostic groups, higher PSAs, or negative and worrisome histopathological features. I'll just give you another minute to read that exclusion criteria, but it does come up again because alongside a longer protocol document, I also felt it was really important for everyone to have a quick reference guide. So I produced a one-page RUH surveillance map, really. It's split across 2 slides, so bear with me, but it does fit on one A4 page in real life, so that it's for easy reference in clinic, in the MDT, and it outlines those 2 surveillance groups, the lower risk and the standard risk surveillance. You can see that even at the time of writing my slides, we still were debating our nomenclature, and we still are, so they are in the old style. But here is our low risk active surveillance. And low risk active surveillance criteria, we're looking for all of the following characteristics: over 65, PSA less than 10, PSA density less than 0.15, a MRI up to PIRADS 3, Gleason 3+3, negative family history, Caucasian, and CPG 1 or 2. In our low risk active surveillance, men will have 3 monthly PSAs for a year, 6 monthly PSAs for 2 years afterwards, and then their PSA will go to an annual PSA. If they're stable at 5 years, then they will come to GP annual PSA screening with a personalised PSA re-referral plan about when they would get referred back in. You'll note there's no DRE in my active surveillance protocol. There is in the longer document about our active surveillance, if a man is unsuitable for MRI, he would be brought up to clinic for a repeat DRE if it was deemed that it was helpful. So there is a caveat in there for men for whom they can't have MRI. Those on the low risk will have a repeat MRI 24 months after their diagnosis and enrolment into active surveillance. They would then have another MRI 5 years post-diagnosis to ensure stability before they get referred back to GP land. In our standard active surveillance, looking at men with slightly higher risk disease, or those who are younger, who have other risk factors such as positive family history or ethnicity risk factors, and these gentlemen find themselves in what will now be called our standard active surveillance pathway, but they have PSAs 3 monthly for 2 years, and then 6 monthly for 2 years. They have their repeat MRI earlier at a year. The reasoning being that we want to make sure that any man with sort of risks of misclassification is caught early, especially as some of these men would be the ones that we wouldn't want to progress or get missed progression. They then monitor their PSA as per the protocol. And again, if they're stable up to 5 years, they'll have a repeat MRI and then be discharged to the GP at that point. If at any point on either pathway there is PSA progression, then that would be a cause for review of the case and consideration of an earlier MRI. If the MRI and PSA progression suggests that there is a change, then biopsies will be performed on a for-cause basis. There are no protocol-driven biopsies in my surveillance pathway. Also, the thing to be aware of is that at each intervention point and contact with the nursing staff, they're asked to review comorbidities, etc. Because if at any point a man becomes unsuitable for radical treatment, say through development of horrific coronary disease, massive stroke, etc., then they would want to transition them out of active surveillance and onto a more watchful waiting pathway. So the ideals, key ideals for the follow-up within my protocol really are to try and make sure that we communicate well with our men, that they know what to expect, and that in doing so, that increases their confidence to stay on active surveillance for longer and not transition to radical treatment unless required to do so. I also want to make sure that we're capturing the right men, the ones that need to be transitioned to active treatment, and that we're not catching those men too late. So it felt very important to me that all men that are suitable for active surveillance should know exactly what treatments are available to them, all the treatments available to them, whether that be being monitored in active surveillance, having focal therapy for prostate cancer, having radiotherapy, or radical prostatectomy. And at the beginning, men go through a number of clinics in the RUH to have all of their options explained to them. If they choose to go down active surveillance, we explore with them what their priorities are and talk about risks, potential treatment side effects, risks, anxiety on active surveillance, and how things might change. We also aim to calculate everyone's prostate predict scores and communicate that with them to help them look at survival advantages of radical treatment, as I think it's other teams have developed very good tools to help us, and Predict Prostate is one of them. It can give an indication at that time of diagnosis what the percentage differences look at 10 and 15 years. And so that should be communicated to our men and stored in their record. They all know who their specialist nurse is and how to contact the specialist nurses here at the RUH. And we want to ensure that they are all aware that they can have access to support at any point through their active surveillance, and that also that we're here to discuss any concerns or worries if they do need to talk to us at any point. As I've mentioned, we want men to remain on active surveillance while they remain fit for radical treatment, but if they are becoming unfit for radical treatment, it would never be an option for them at that point, then it's kind of to transition them to watchful waiting. And as I've mentioned, at our nursing interventions, these things are discussed. So how do we deliver active surveillance at the RUH? I've talked to you about my protocol and how it's been spread into the two different streams. We identify the men at MDT. We define their active surveillance category. They're seen in a results clinic and given information about all of the treatment options available to them. Chances to meet surgeons and oncologists if radical treatments are also an option. They then go into a specialist nurse-led active surveillance with a personalised PSA cutoff for intervention, and they are informed and they have access to their PSAs, but they're prompted by our administrative pathway coordinators when to get a PSA test. There's then nursing telephone update clinics at which their MRIs, etc., are arranged. They exit to the GP at 5 years post-diagnosis if stable, and if they become unstable or disease progression, transition to treatment, or if they become unfit, transfer to watchful waiting. So I don't have much time left, so I'm going to wrap up for you quickly. But there are other active surveillance pathways out there, and there have been consensus meetings and groups such as Vincent's group in Cambridge, who have done excellent work with the stratified cancer surveillance. And the StratCans website, if you haven't visited it, is somewhere you should definitely go. There needs to be more research into what is the optimum use of MRI and etc. in active surveillance, and as yet we don't really know if pathways like mine fully work. And we will be recording it and auditing it and ensuring that we are keeping good data. But there is still work to be done on pathways, and I do implore you to look at the StratCans website and have a look at the wonderful work that's been done there. So what are some other further refinements that I'm looking to make for my active surveillance? At the moment, our men get the results and chat about what their options are sort of all at the same time. That can be very overwhelming. So I wonder whether we need to do a small split in results giving and decision making, although they do get plenty of time to mull over options. I also don't have yet personalised exercise prescriptions and wellbeing programs for men on active surveillance, but I'm very keen to embed this, as I think it's a perfect opportunity, as I said earlier on, to improve men's cardiovascular health, and that's likely to improve their survival over anything we do in terms of prostate cancer treatment. We also used to have local active surveillance patient groups, and unfortunately these events were stopped during COVID, but I think that camaraderie and that peer support is really important, and I'm hoping to get that up and running back in Bath. So what do I think the priorities are nationally? Well, it'd be nice if we could remove regional and national variations, if we could all stick to one standard pathway, a bit like we do for bladder cancer surveillance, and explore better ways to support men around their anxiety-provoking event times. I also think it's important that we look at that health and well-being and personalised exercise while on active surveillance. And in fact, a number of my PC UK clinical champion colleagues are looking into just that. So I think it is really important that we continue to work as networks, and I can only thank PC UK for the opportunity they've given me to really improve my network, as I think lots of these things, we don't all need to reinvent the wheel. We just need to work together to improve the care that we give our men. So thank you for listening to me, and I am happy to take any questions.